So our next panel is on health and mental health issues of children in immigrant families. And this will be moderated by Dr. Bonnie Maldonado. Dr. Maldonado is the Senior Associate Dean for Faculty Development and Diversity. Welcome.
Thank you, Jason, and thank you again for the wonderful panel and the rest of the day. I'm also a pediatrician, by the way, so these are issues that are near and dear to my heart as well. So I want to introduce my panel members. I'm going to introduce them all at once, and we're going to take questions at the end of all three of the discussions. So first of all, to my immediate left is Dr. Elena Fuentes Afflick, and she is Professor and Vice Chair of Pediatrics at UC San Francisco. She's also Chief of Pediatrics at the Zuckerberg San Francisco General Hospital and Vice Dean for Academic Affairs and Faculty Development in the School of Medicine at the University of California in San Francisco. And she has quite a distinguished career, as do the other two of our faculty panelists. She has trained in pediatrics at UCSF, and then did a fellowship in health policy at UCSF and an MPH in epidemiology at UC Berkeley, and has had several national leadership roles, including president of the Society for Pediatric Research, on the Council of the National Institute for Child Health and Development, and the American Pediatric Society. And she's also was elected to the Institute of Medicine in 2010. Now, to her left is Dr. Glenn Flores, who is Professor of Pediatrics and Public Health, was Professor of Pediatrics and Public Health, Director of General Pediatrics, and the Judith and Charles Ginsburg Chair in Pediatrics, and at the UT Southwestern and Children's Medical Center in Dallas. He's currently the Chief Research Officer at Connecticut Children's Medical Center. I understand he's making that transition now. And he's also published widely in the area of Latino health and disparities in health and healthcare. And he's received a number of awards and funding from various federal organizations in this area. And then finally, last but not least, I'd like to introduce Ryan Matlow, who is the Director of Research Programs for the Early Life Stress and Pediatric Anxiety Program here at the Stanford University School of Medicine. And Ryan he received his doctoral degree in child clinical psychology from the Department of Psychology at the University of Denver, and completed pre- and postdoctoral fellowships in the Multicultural Clinical Training Program at UC San Francisco General Hospital. So I'd like you to welcome our panelists, and we'll start with Dr. Afflick, Fuentes Afflick. Thank you.
Thank you, Bonnie, for your introduction. Thank you, Fernando, for inviting me to participate in this very important meeting. I am really honored to be here and hope to contribute something to our discussion today. My work has been really in perinatal epidemiology, and what I'm going to do is present to you some information about the health of Latina women. We'll also talk about immigration and acculturation. Those of us who have gone to either medical school or public health school have learned about risk factors for prematurity. We could substitute infant mortality or low birth weight because they tend to run together. But we learn about risk factors so that we can mitigate them and hopefully reduce their impact on outcomes. So many of you learned the same list of factors that I learned, which includes ethnicity, non-white ethnicity specifically as a risk factor. We also learned that age is an important factor, socioeconomic status, marital status, etc. So we carry around these ideas of risk factors in our head when we approach patients and deal with them. And what I found when I came to California after going to medical school for my internship and residency was that there was a bit of a mismatch between these sets of risk factors that I had in my head and the experience that I had with patients. Because I found that my patients had a long list of these risk factors, and yet when I took care of them, the women were largely healthy, they largely delivered healthy babies, and then they went on pretty much to be healthy children. So it really didn't make sense. How do you compare this list of risk factors with what you're seeing, and how do you decide who is really at risk for bad outcomes? Well, I wasn't the only person who didn't really understand how to put this all together, and I apologize if I'm repeating anything that you heard this morning from some of the distinguished speakers, but This paradox between what should be bad outcomes with what is relatively good outcomes is what we now call the epidemiologic paradox. And the term was coined in the 1980s when researchers started to look at the health experience of Latinos. Although Latinos have been in this country for many, many years, generations in fact, we really didn't start to look at health status among Latinos until the 1970s or so. And so this paper, which was published in the 1980s, looked at mental health service utilization among Latinos in the Southwest. And again, they expected to find that the population would have high rates of utilization, high rates of mental health problems. But what they found was low rates. So again, this mismatch was where the term, the epidemiologic paradox, really came from. In the area of perinatal health, one of the very earliest studies was an analysis of data from the state of Texas over the decade of the 1970s. Moving chronologically left from right, several things to notice. First of all, the axis is percents. We now don't think of percents anymore. Thankfully, we've had improvements, so now we think about rates per 1,000 rather than 100. But at this time, we were still having much more mortality than we did now. But what you'll see is that over the decade of the 70s, while the rates of mortality fell for all three ethnic groups depicted in the slide, there's still this pattern of overlap between Latina and white women, depicted in blue and pink, and the higher rates among African American women. When the authors interpreted their findings, they really didn't know how to interpret it because this is not what they expected. They thought that the Latina and African American women would have the overlapping rates and the white women would be lower. And so what they decided in terms of interpreting their findings was that it must be related to underreporting, meaning that women were delivering babies and then either going off perhaps to a rural area if their baby died, or going back to Mexico where their baby would be immortal from a US perspective. So they attributed this surprising finding to underreporting. A study a few years later from Harris County, Texas, which is the county that includes Houston, so the authors were trying to pick a place that was farther from the border, so it wouldn't be so easy. And remember, this is the 1970s when people didn't just hop on a plane and go everywhere the way we do now. But in the 1970s, they looked at Harris County because they thought, well, this will be more of a closed community, if you will. And what they found there for both neonatal and post-neonatal mortality was essentially the same as what people had reported in the 1970s. Because for both mortality outcomes, Latina and white women had basically similar rates and lower than the rate for African American women. But these authors didn't believe their results either. And what they concluded was that the mortality rate was just not a good indicator of health for this population. Now, if you've studied public health or medicine, you know that we consider infant mortality one of our most important indicators of societal health status. So to say that it's not a good indicator for this population is really flying in the face of what we consider good measures. Then in California, Ron Williams and his colleagues looked at low birth weight. These are data for the entire state of California. And again, what they found was the same kind of finding, the same pattern of overlap between Latina and white women and lower rates than what was reported for African American women. In one of our early studies, we looked at what was then the reported literature in low birth weight according to ethnic group. And it's really chronologically from left to right. And you'll see that while the rates vary over time, it's the same pattern. We see the overlapping and virtually similar rates for Latina and white women as compared to the much higher rates among African American women. So it's not a 1970s phenomenon or a 1980s or a Texas or a California. This is a reproducible and consistent finding. Now, you know that if we talk about Latino health, we have to talk about immigration, and not just because we're here to talk about that today, but the issue of ethnicity and birthplace is very tightly linked for Latino health. So as a brief overview, and again, forgive me if I'm repeating what you already discussed this morning, but our immigration status, our current immigration bill is from 1965, the Hart-Celler Act. Up until that time, our immigration policy was based on quotas. And so the number of people admitted every year was some proportion of the population that had been here in 1900, 1910, 1920. But then the Hart-Celler Act said, no, let's do away with the national quotas. Instead, we're going to emphasize family relationships, so reunification of families became an important criterion, and skills. We will allow entrance for people who bring skills into our country that we want to foster. And immediately what happened in terms of the U.S. immigration population was an influx of immigrants from Asia and from Latin America. There's several definitions of acculturation. This is one of my favorites, and it describes acculturation as a process by which immigrants adopt the attitudes, values, customs, beliefs, and behaviors of a new culture. So it's multidimensional, and that also means that it's hard to get your hands around. It's hard to measure. It's really hard to quantify, but it captures the richness of the phenomenon. When we think about how acculturation might influence health outcomes, it could go one of three ways. It could be greater acculturation could be associated with worse outcomes. It could not have any effect on outcomes, or it could be associated with better outcomes. And in part, the way that we expect that relationship to go depends on what we think about the immigrants and who are they and what are their risk factors. Because if we assume that immigrants are disadvantaged compared to the native-born population, then we expect them to have worse outcomes. On the other hand, if we expect immigrants to have come with advantages into the country, then we might expect that they would have better outcomes than the native population. I'm only going to show you two slides of data that we've done around immigration status, because for the most part in the world of research, including my own, we've focused on birthplace, although I would be the first to admit that it's a crude measure of acculturation. In one study that we conducted, we interviewed a large cohort, 3,000 Latina women from the Bay Area, at the time that they delivered a baby, and we asked them a whole lot of questions. And the questions that we asked at the end were related to their immigration status. So we had kind of softened them up with a lot of questions before we got into the tricky stuff. And what they told us in this population, includes people from Kaiser, people from the General, where I and several of my colleagues work, people from other hospitals. And in this cohort of women, 56% of them told us that they were undocumented. Now, if anything, this might be an underreporting, but it's an astounding proportion of women who would admit to being undocumented. And when we looked at the relationship between immigration status and the use of health services, I think it's reassuring that we did not find statistically significant differences in the use of preventive care services. So there was no difference between the citizen, documented, and undocumented women in that measure. But we did find that the undocumented and the documented women were less likely to use dental care services than their citizen counterparts. And given the evolving nature of our understanding between oral health and physical health, this would suggest that we need to work closely with our colleagues in dental health to make sure that we are addressing health needs. I'm going to run you through some of our perinatal information. And here I'm going to focus primarily on birthplace as our measure of acculturation. In this study, we looked at Latina women who had delivered in the state of California in 1992. You know that we have about 600,000 births in the state of California. 15% of all U.S. births occur here. So we have an incredible laboratory to look at perinatal outcomes. And when we analyzed very low and moderately low birth weight as a function of maternal birthplace, we found that there was no significant difference in the odds of very low birth weight between foreign and U.S.-born Latina women after adjusting for all the things that you can adjust for on the birth certificate. But in the moderately low birth weight outcome, we found that the foreign-born women had a 9% lower risk of delivering a moderately low birth weight infant. That may not seem significant to you, but I see our colleague and the director of the Department of Public Health. If we had a 9% reduction in the incidence of low birth weight, people would be running through the streets because it would really be a major accomplishment. But this slide shows that there is a paradox. It's a demonstration of the paradox. First, because there was no difference in the risk of very low birth weight between the foreign and US-born Latina women. And then, even more evidence of the paradox is that the foreign-born Latina women had a 9% lower risk of moderately low birth weight than their US-born counterparts. We've looked at prematurity as well as a function, same setup. In this study, we analyzed Latina and white women, and this is now a US cohort, so not just California. And in this case, the foreign-born women were 18% less likely to deliver a very preterm infant and 8% less likely to deliver a moderately preterm infant. Now we're starting really to talk about some significant differences. So again, this is another demonstration of the paradox, because very premature and moderately premature outcomes are very significant from a public health standpoint as well as from an economic and medical standpoint. We've looked at infant mortality in California, and here you have to look at multiple years because thankfully infant mortality has become less common. But in the unadjusted models, the foreign-born Latina women were 8% more likely to have their baby die in the first year of life. But after we adjusted for all the factors that we can include, the odds went down to 88%, so 12% lower than their US-born counterparts, which demonstrates, first of all, that you need to do the multivariate adjustment. These risk factors, even if they don't completely explain it all away, are still contributing, so they are important. But at the end of the day, after we adjust for them, we are still left with a pattern of findings that we can't fully understand. Some people believe that we need to think about Latino health in a community context, that focusing just on the individual may be too narrow or may not be the right way, that we need to zoom out and think about the community at some level. And we've done some work. Again, in this study, we are looking only at Mexican origin Latina women who delivered in the US. And we are comparing where the mother delivered and where she said she resided. And what you see is that there's a gradient for both low birth weight outcome on the left-hand side of the slide and prematurity on the right, with the lowest risk being the women who were born in Mexico, and they reported a Mexican residence. Now, I will remind you, they all delivered in the US, so we have to take it with a little bit of a grain of salt, but maybe they had not been here very long before they delivered. But you see that gradient of risk, with the highest risk for those Mexican origin Latina women who were born in one US state and delivered in the same US state. So this suggests that there is something about the interplay between the individual and the place of residence. And in another study done with some colleagues who are at Hopkins, we looked at the concentration of immigrants, Latino immigrants in particular, in the county where the woman lived. Because you might speculate that if you live in a same ethnic community, you might have more support. People might be telling you what to eat or what to do, or I'll watch your baby while you go to the prenatal care appointment. But what we found in this study was a little counterintuitive. First, on the right-hand side of the slide, we found that very preterm infants were much more likely to die in the first year of life. That makes sense. We know that from our medical studies. But what we found on the left-hand side of the slide was that for the foreign-born women who lived in higher immigrant communities, those babies had a higher risk of dying in the first year of life, not a lower risk. I don't know exactly if this is enough to disprove or really question things, because we don't really know what are the best measures of those community factors. But at least it suggests that it may be a little more complicated, and we need to partner with colleagues in epidemiology and social epidemiology. Because we've approached these issues very much from a one-size-fits-all. Give us a list of risk factors and we apply it, and we can identify who will have a bad outcome. But we know that's not true. I already showed you some information about ethnicity and outcomes. This is another study where we looked at neonatal and postneonatal mortality. And again, you'll see that the African American women were much more likely to have a postneonatal death, whereas the Latina women in the same study for the same outcome were less likely compared to white women. So we need both to understand the favorable part for the Latina women and the at-risk part for African American women. And again, the same thing for moderately low birth weight, but this one looks specifically at the birthplace. And what we see is that the effect of birthplace is not consistent across ethnic groups. So whatever you think about what immigrant health is, what it means, is it a mindset, is it whatever, how do we explain why it works in one community, one ethnic group, but not in another? That's still an unanswered question. Now, you might wonder, most of what I've shown you is from the 90s, early 2000s. I'm going to show you this slide, which is the most recent data from the National Center for Health Statistics, to demonstrate to you that when we are looking at maternal risk factors, young age, non-married status, and U.S. born, we're seeing a lot of the same pattern of risk factors. So while outcomes may have improved, we're still seeing pockets of risk factors among women according to their ethnic group. And when we look at outcomes, we're still seeing the same thing. So it's as true in 2015 as it was in 1995 or 2005, where African American women still have a higher risk of delivering a preterm infant, of having a low birth weight infant. And cesarean is interesting. We also see some ethnic differences there. So I'm going to leave you just with these three questions that we don't yet have answers to, but I hope that some of you, we will spark conversation and perhaps spark further study to ask, why do African American women have an elevated risk of adverse outcomes? We don't understand that. On the other hand, why do Latina women have a lower risk? We don't understand that one either. And in general, why do foreign-born women, but foreign-born Latina women in particular, have a lower risk of adverse outcomes? These are questions that we are left to consider, hopefully develop both clinical studies, translational studies, and policies so that we can support health for our population. Thank you.
Well, good afternoon. I'm going to talk about the health and healthcare of immigrant children in America and meet the challenge of doing that in 20 minutes. So, immigrant children are the fastest growing group of American children. 1 in 4 U.S. children, as you heard earlier, are either first or second generation immigrants, and that's equivalent to over 18 million, and 90%, almost 17 million, are U.S. citizens living in immigrant families. 65 million Americans, so that's 22%, speak a language other than English at home, and 26 million, that's 9%, have limited English proficiency, which I'm going to refer to as LEP. Among school children, 12 million, so that's 22%, speak a language other than English at home, and 3 million, or 5%, are LEP. Latinos at 55% and Asian Pacific Islanders at 17% among children comprise about 3/4 of all immigrant children in the United States. And from 2000 to 2010, the U.S. Census shows that white children in America actually declined in population by 4.3 million, whereas Latino and Asian Pacific Islander children increased by almost 6 million. So immigrant children experience major health insurance disparities. Immigrant children are substantially more likely to be uninsured than citizen children. Undocumented children are 4 times more likely to be uninsured versus citizen children. And citizen children in mixed immigrant families, that's where there's at least one immigrant parent, are twice as likely to be uninsured versus citizen children with citizen parents. And here's some of the latest data from the CPS, current population survey. Your y-axis is a proportion, x-axis. First, we're going to look at kids, and as you can see in the light blue, the undocumented, 23% uninsured. That's 4 times higher than citizens in the red at 6%, and then lawfully present children as well, about 3 times the risk, 17%. I put the non-elderly adults there as well, just to show you that there are even higher rates of uninsurance, and we get concerned about that as people who care for kids, because if you have a parent who's uninsured, that makes you much more likely as a child to be uninsured. And there are adverse consequences of not insuring immigrant children. So we know that uninsured children are significantly more likely than insured children to have worse health status, to lack a regular physician, to delay immunizations or be unimmunized, to have higher unmet needs, to make ED visits, to experience preventable pediatric hospitalizations, to be hospitalized after injuries, to have adverse outcomes as newborns, and to die during hospitalizations and admissions to pediatric intensive care units. It costs all Americans more when we don't insure immigrant children. These children frequently end up getting more expensive ED care rather than outpatient care and are hospitalized for preventable conditions. The high costs of uncompensated care for this frequently preventable, expensive acute care is passed on essentially as a tax on the privately insured and in the form of increased property taxes to pay for care in public hospitals. And there are imminent policy threats to the health insurance coverage of immigrant children. So federal CHIP funding is set to end in September in only a couple of months for 8.4 million CHIP-covered children. And current congressional legislation, as many of you are aware, to impose Medicaid per capita caps or block grants would severely threaten access to care for millions of immigrant, poor, and vulnerable children. You may not know this, but Medicaid is the largest insurer of U.S. kids, covering 37 million. And major disparities exist in the overall health care of immigrant children. So despite the dramatic population growth of Latino and Asian Pacific Islander children, racial and ethnic disparities in children's health and health care are extensive, pervasive, and persistent for these predominantly two immigrant groups. So a recent comprehensive report by the American Academy of Pediatrics documented that children's disparities occur across the spectrum of health and health care for these two groups, and they include things like mortality, access to care and use of health services, prevention and population health, health status, chronic diseases and special health care needs, and the quality of care. And so let's examine some disparities among Latino children. We know that they have a wide range of disparities in access to care and use of services, including much greater odds of being uninsured, having no usual source of care or health care provider, going one or more year since the last physician visit, not being referred to a specialist, and never only sometimes getting medical care without long waits. We know there are disparities in breastfeeding, injuries, violence victimization, obesity, physical activity, and nutrition, and they have double the odds of suboptimal condition of the teeth. They have higher risks of death for those who get leukemia and after congenital heart surgery. Teen girls have a birth rate that are 3 times higher than whites and the highest of any racial or ethnic group. Latinos have the highest youth rates of feeling sad or hopeless, 33% overall, 41% in girls. Making a suicide plan in the past year, 14% overall, 18% in girls, and attempting suicide, 10% overall, 14% in girls. And major disparities in mental health care exist. You'll hear more about that with the next speaker. These include higher unmet needs and lower odds of any mental health visit, antidepressant prescriptions, and treatment by mental health specialists for any condition, specifically for behavioral problems or specifically for depression. And for Asian Pacific Islander children, they are more likely to have no usual source of health care, to have made no visit to the physician or other provider in the past year, and to have gone more than 1 year since their last physician visit. They have lower odds of seatbelt use, sunscreen use, and weekly physical activity, and higher daily hours of TV and video game screen time. They actually have the worst access to specialty health care of any racial ethnic group and higher risks of injuries, lead intoxication, and obesity. And in terms of some other adverse health and healthcare outcomes, our team in a nationally representative study documented that children in non-English primary language households have a significantly greater adjusted odds of suboptimal medical and oral health status, including triple the odds of the health not being excellent or very good, and double the odds of the teeth condition not being excellent or very good, impaired access to medical and dental care with almost 4 times the odds of being uninsured, double the odds of having no dental insurance, no usual source of medical care, and problems getting specialty care, and lower use of medical and dental services, including no preventive medical visit in the past year, and more than 1 year since the last dental visit. And I want to present to you a real case of a child with serious chronic disease, an immigrant child. So this is published in Pediatrics. LC is a 10-year-old undocumented Mexican boy recently hospitalized for acute renal failure who presented to a community health center. He reported normal urine output, but labs revealed hematocrit of 24%. For those of you who are not a physician, that's anemia, and then those other 2 labs, BUN and creatinine, are consistent with renal failure. They did a renal ultrasound. It showed hyperechoic small kidneys bilaterally, consistent with chronic renal failure. And pediatric, sorry about that. And so the PCP, I'm sorry, my slides are going off here. There we go. So the renal ultrasound showed chronic renal failure. The pediatric nephrologist informed the PCP that they would provide phone consultation to manage the patient, but the hospital's policy actually forbid dialysis or kidney transplants for undocumented, uninsured patients. The PCP explained to the family that LC would need dialysis while awaiting a kidney transplant. Elsie's mother didn't want to return to Mexico for her son's care because she had no health insurance in Mexico, was uncertain he would receive needed care, and didn't want to leave her extended family who now lived with them. The PCP discussed the case with several pediatricians in leadership positions at the hospital, including a member of the hospital ethics committee. She tried to convince them to make an exception for Elsie. The hospital administration, however, refused, noting that it was already covering chronic dialysis costs for 2 other undocumented children who had started dialysis prior to the policy. The PCP found a pediatric nephrologist in another state willing to dialyze LC. This nephrologist suggested that the family move to get care at his hospital, which actually had no formal policy of limiting care to undocumented children. 1 month later, LC and his mother moved 1,200 miles to this state, initially living in a homeless shelter. LC started dialysis 1 month after arrival. Subsequently, several local Latino community and religious groups, a local children's hospital, and area newspapers spearheaded fundraising campaigns to raise $75,000 for his kidney transplant. And finally, 14 months after arrival, the family had raised sufficient funds for the transplant, and the mother donated one of her kidneys to her child. So we heard about the healthy immigrant effect, and I just briefly want to talk about that in relation to generational status. So as you heard, although immigrants often have a higher prevalence of risk factors associated with worse outcomes such as poverty and uninsurance, lower acculturation, so less Americanization, is associated with better health outcomes, including higher immunization rates and lower rates of teen pregnancy and alcohol, drug, and tobacco use. But Dr. Mendoza right here and his colleagues showed that first-generation Mexican-American children have significantly worse health and healthcare outcomes when you compare them with their second and third-generation counterparts and with whites, including the worst health status of those groups and the lowest rates of insurance coverage, usual source of care, and seeing a physician in the past year, which calls into question the healthy immigrant effect, at least in this context, and also indicates that we need to think about this in a more nuanced way. So I want to talk next about language in healthcare. So a large body of literature documents that language problems impact multiple aspects of healthcare. These include access to healthcare, health status, use of services, patient-physician communication, satisfaction with care, research, and quality and patient safety. So at an inner-city primary care clinic, we found that 26% of mothers of Latino children cited language problems as the single greatest barrier to health care, and these included the staff not speaking Spanish and a lack of interpreters. And 6% reported deferring their medical visits, not bringing their child in because of these language problems. And the hazards of using ad hoc interpreters, which it still occurs far too often, so these are family members, friends, strangers pulled from the waiting room or the street, or custodians, include the patient is less likely to be told about medication side effects, the interpretation errors are more likely to have potential or actual clinical consequences versus those made by professional interpreters. Family members can misinterpret anywhere from a quarter to a half of questions asked by physicians. Children who are forced to interpret are often embarrassed by and tend to ignore questions about things like menstruation, bowel movements, and other bodily functions, and non-medical staff who interpret can exclude or distort clinical information. And recent studies document the especially egregious hazards of using ad hoc interpreters for LAP cancer patients. So as examples, the physician said, we think there is a 40% chance that the treatment will prolong your life. The interpreter interpreted this as the treatment will prolong your life. Another physician said that doxy could hurt your heart, referring to a chemotherapeutic agent. Interpreter interpreted this as that doxy can give you pain. Another physician said the results of these tests lead me to conclude that you do have breast cancer. The interpreter said this test will tell me if you have cancer. And finally, one important thing that you have going for you is the fact that the cancer has probably been caught early. Interpreter says one important thing is the fact that the cancer is working quickly in your body. And in the study of a major pediatric residency program, researchers found that 68% of residents spoke little or no Spanish. Over half of non-Spanish proficient residents use inadequate language skills in patient care often or daily. Many residents reported LEP families under their care never or only sometimes understood their child's diagnosis, medications, discharge instructions, and the follow-up plan. 80% avoided all communication with these LEP families, and although all of these residents agreed that hospital interpreters are effective, 75% reported never or only sometimes actually using hospital interpreters. And in a study of 128 pharmacies in a major U.S. city, a medical student of mine found that about half of pharmacies can never or only sometimes prepare non-English language prescription labels. Over half never or only sometimes can provide non-English language information packets, including 15% who can never do so. And about 2/3 of these pharmacies never or only sometimes can orally communicate in non-English languages, including 1 in 6 who can never do so. And the combination of LEP and limited health literacy are especially deleterious. In a recent study by Dr. Standers here, it was just published this month, I believe, of Latino parents revealed that parents with the combined LEP and limited health literacy had significantly greater likelihood of making medication dosing errors versus English proficient parents with adequate health literacy at 29% versus 13%, an adjusted odds ratio of 2.2. And in terms of health processes, outcomes, and use of services, we know that interpreter services done correctly can positively impact health outcomes. For example, one study showed that in children presenting to the emergency department, LEP patients with professional interpreters did not differ from the English proficient patients in test costs or use of IV hydration, and actually had a lower likelihood of testing. And here's some examples of quality and patient safety issues for LEP patients. So a 2-year-old fractured her clavicle after falling off her tricycle. The resident physician misinterpreted 2 Spanish words, se pegó, diagnosed child abuse, and contacted the Department of Social Services, who, without an interpreter, had the mother sign over custody of her 2 children. A 10-month-old girl with iron deficiency anemia was given a 13-fold overdose of iron and hospitalized for iron intoxication after her LEP parents were given medication instructions and a prescription only in English. The parents gave 15 milliliters, so that's a tablespoon of iron elixir, based on a prescription label that read 15 milligrams per 0.6 milliliters, 1.2 milliliters daily, so that's a dropper. And in a famous case, misinterpretation of a single Spanish word, intoxicado, in Florida resulted in an 18-year-old's quadriplegia after being misdiagnosed with a drug overdose. The patient's hematomas, brainstem compression, and paralysis were due to a ruptured aneurysm, and the hospital paid out $71 million in a malpractice settlement. And here's an example we published in the New England Journal of a study that we did of interpreters. This is adverse consequences of having no interpreter. So this is a 12-year-old who came to the emergency department with dizziness, and he had to act as his own interpreter for both himself and his mother. So the mother says, la semana pasada él le dio mucho mareo y no tenía fiebre ni nada, y la familia por parte de papá todos padecen de diabetes, which means last week he had a lot of dizziness, he didn't have fever or anything, his dad's family all suffer from diabetes. So the teen says nothing, and the doctor says, uh-huh. So then the mother says, a mí me da miedo porque él lo que estaba mareado y no tenía fiebre ni nada, which means I'm scared because he's dizzy, and he didn't have fever or anything. So the teen doesn't say anything again. The doctor says, okay, so she's saying you look kind of yellow. Is that what she's saying? And the patient turns to his mother and says, es que si me vi amarillo, which means, is it that I looked yellow? And the mother says, estaba como mareado, como pálido, which means you were like dizzy, like pale. So the patient turns to the doctor and says, like I was like paralyzed, something like that. And here's a case, Juan. Juan was a 6-month-old, previously healthy male who presented to a children's hospital ED with new onset vomiting and diarrhea. The triage history given by mom was interpreted by Juan's 12-year-old sister. The sister stated that the patient had 4 dirty diapers and 3 episodes of vomiting that day. Juan was triaged to a non-urgent level of care in which documentation stated he had vomited 7 times that day with no diarrhea. He was discharged shortly thereafter with a diagnosis of vomiting and instructions in English only for PDI by mouth ad lib. 3 days later, Juan returned to the ED in severe distress with new onset of bloody stools. He was admitted to the hospital, and Juan tragically died 6 hours later of septic shock. But only 12 states and D.C. provide reimbursement through Medicaid and CHIP for interpreter services. Unfortunately, most states with the largest numbers of LEP patients, including your state of California, as well as New York and Texas, have not followed suit, and that would be a great advocacy project that we could talk about afterwards. And then the toll is really big on children of parents who have undocumented status. So one study showed that Mexican-American children less than 6 years old with undocumented parents have a 50% greater risk of poor development versus white children with U.S.-born citizen parents. Another study revealed almost half of Latino immigrant parents said that the threat of deportation affected their child's emotional and mental well-being. And almost 3/4 of undocumented parents reported their children experienced PTSD symptoms versus 40% of documented parents. Between July of 2010 and September 2012, over 204,000 parents of U.S. citizen children were deported. In 2015, estimates indicated that over 78,000 undocumented immigrants were deported from the U.S. who had U.S. citizen children less than 18 years old. More than 5,000 children of immigrants languish in foster care in the U.S. because their undocumented immigrant parents are detained or deported by federal immigration authorities. And these children can spend years in foster homes, with some put up for adoption after termination of parents' custody rights. With neither state nor federal officials addressing this problem, thousands more are poised to enter the child welfare system every year. And in 2016, almost 60,000 unaccompanied children and about 78,000 families sought asylum or were apprehended at our southern border. The U.S. actually has the world's largest immigration detention center, detaining up to 442,000 persons per year, many of which are children. And Homeland Security Secretary Kelly is considering separating children from parents caught crossing the border as a deterrent. So in conclusion, immigrant children are at very high risk of uninsurance. CHIP could be eliminated this year, and Medicaid could be severely cut, with devastating consequences for immigrant children's health and health care. Major disparities exist in the health and health care of immigrant children. Language barriers have substantial adverse consequences for immigrant children's health care, and parental undocumented status takes major mental and physical toll on children. Tens of thousands of children are separated from their parents every year, and Homeland Security Secretary is considering separating these children from their parents caught crossing the border as a deterrent. So I finished with some policy solutions to optimize the health of immigrant children. We must provide health insurance to all children, including the undocumented. That currently occurs, as somebody asked earlier, in D.C. and 5 states. California is one of them, also Illinois, Massachusetts, New York, and Washington. And we must aggressively advocate for CHIP reauthorization and no Medicaid block grants or per capita caps. All children should have access to needed specialty and mental care, medical and dental homes, which can be provided through continued support and expansion of federally qualified health centers, as we heard before, and other safety net providers, providing incentives and loan repayment programs for primary care providers based on the number of patients receiving care in medical and dental homes, and of course, diversifying the healthcare workforce. No child should be denied health care or suffer injury or death due to language barriers. A federal report estimated that would cost on average only $4.04 more per physician visit. That's only about a 0.5% increase in our entire nation's healthcare expenditures to provide all U.S. LEP patients with appropriate language services. And the time has come for our nation and for California to provide third-party reimbursement for medical interpreter services, not just in Medicaid, Medicare, and CHIP, but through private payers as well. And this should be a high priority in immigration reform. And finally, we must protect immigrant children by never separating them from their parents and placing them in foster care. We must allow parents to make calls to arrange for care of their children soon after detainment. We have to require ICE to consider children's best interests in detention and release and transfer decisions affecting parents. We have to ensure that children can call and visit their parents during detainment. We have to guarantee that parents can participate in family court proceedings affecting their children and the ability to coordinate departures with their children, and we should provide free counsel for unaccompanied minors. Thank you.
Thank you. I don't have any slides, so I'm going to speak from here. Thank you for having me. It's a pleasure to be here and to have this opportunity. I'm going to speak a little bit about a couple of things that concern me about the mental health of children from immigrant families. But one thing, I appreciate the conversation that has been happening today, people sharing personal stories, the focus on narratives, experiences of children in immigrant families. This personal reflection, I think, is very important for us as providers, to be thinking about our motivations for doing this work, right? It's also important to reflect on our own experiences with immigration and culture, because our experiences interact and intersect with those of the patients and clients and children that we're caring for. So I thought I would share a little bit of my story, some reflection that I've done. Folks that focus on issues of race and bias ask the question about the reflection question of when did you receive your first lessons about race? What's your first memory of racial differences, right? And engaging in this sort of reflection is important, right? Particularly for folks working from positions of power and privilege. Because what we'll learn is that you start to see and understand that folks, when we're speaking about race, people of color often have these experiences earlier than folks from positions of power or privilege, often through experiences of difference and discrimination, right? And it's important to acknowledge some of these differences. So the same sort of question can be applied to immigration, right? When did you first receive your first lessons about immigration, or about what does it mean to be an immigrant? And so I've reflected on this a little bit for myself. And I think back to, I grew up in a farm in Santa Cruz County, in largely a farm working agricultural community, with a lot of migrant, immigrant farm workers, right? And so I went to a bilingual elementary school. A lot of my friends growing up were from immigrant families, right? And so when I have reflected on this question for myself, I think about an early experience. I must have been in third grade or something like that, where a friend of mine, a Latino friend who I played with on the playground and everything, he's from a Mexican family. In the classroom, the teacher was, the school was providing a handout, a resource specifically for immigrant kids and families, for the migrant families, right? So it's an informational letter or something like that. And I remember this handout going out to some of the kids, some of my classmates, and she came to my friend Marcos and went to give it to him, and he said, no, that's not for me, right? And she said, no, take it home, give it to your parents. And he was like, no, that's not mine. That's not my family, right? And it seemed like a small moment there, but it was a memory that stuck with me and kind of puzzled me for a while, right? And obviously, in that moment, I didn't exactly know what was going on, but over the years, I came to reflect on that experience and that incident, and came to understand that he was ashamed and a little bit embarrassed about his immigrant status, right? And at this young age, at 7, 8 years old, he had begun to internalize some of the messages that are out there about what it means to be an immigrant, right? That this was already something that he was struggling with in his own identity, right? So this is one thing that concerns me, right? And so as national leaders, national and international leaders are putting messages out there describing immigrants as criminals, as terrorists, as being unwelcome, right? Enacting policy that puts up bans and barriers and literally builds walls, right? We'd like to think that this doesn't affect kids, right? But it does, right? Kids start to internalize these messages. It affects their self-identity, their self-esteem, their sense of self, their sense of belonging in the world, in society, right? And so these are some of the things that we deal with, that we work with in mental health, right? And we know that this has long-term consequences, right, as kids start to internalize these messages. The research that's been out there around, the great research that's been done around the impact of implicit bias and stereotype threat, right, shows us that, even if someone doesn't ascribe to, some of the messages and attitudes that are out there, just the mere presence of some of these stereotypes about certain social groups, or in this case immigrant groups, affects performance, right? Affects how kids do in school and on tests and things like that. And clearly, we can start to draw out a trajectory this shows kind of the negative consequences of these messages, right? This can contribute to what we see when we talk about, the school to prison pipeline, right? In a lot of ways, these messages can be a bit of a self-fulfilling prophecy, right? So this is one area that concerns me, is the internalization, the way kids internalize and adopt some of the messages that are being propagated and that are out there by leaders in the world, right? Another thing that we're seeing in our clinics and working with kids from immigrant families is something that's been mentioned in a lot of the previous conversations earlier today, is that we're seeing an increase in general distress, right? In anxiety and fear and sadness, right? And this is directly related to, as folks have pointed out, as previous panelists have pointed out, this is directly related to the legislation, the messaging and enforcement actions, speaking about deportation and ICE raids and things like that, that's happening right now. And so these actions provide a direct threat to kids' sense of safety and stability and security. And we know that these are the core elements of mental health, right? When people feel in threat, or that they're under threat, when they feel that they're not safe, that they don't have stability in their lives, right? Then this is distressing, this disrupts mental health, right? And so we see kids coming in with everyday chronic worries about, is my mom going to be home when I get home, right? Is ICE going to come and get my family or get me, right? And this is an everyday anxiety that we see kids coming into our clinics thinking about, right? And other folks have mentioned this as well. We're also seeing grief reactions, right? Symptoms of sadness and depression in kids who have already experienced losses, right? That have already experienced separations due to deportation or due to bans or whatever it may be that have prevented, reunification with caregivers and family members, right? This is a major disruption in kids' lives. Another, experience that folks have mentioned is bullying, right? As there's been a sort of kind of, in some ways, a permission that's been given to target immigrant communities, right? And so, bullying is kind of, a hate crime being played out, in a child's level, right? And so, everyone can kind of, I think, understands the impact of being bullied and how this affects mental health. So these are daily chronic worries and experiences that kids are going through right now, kids from immigrant families are experiencing. And this clearly has an impact. In our early life stress program here, we seek to understand and address the impact of trauma and adversity on kids and child development. And one thing that we think about is not just specific experiences of stress and trauma, right, but the cumulative burden of chronic experiences of stress and trauma and adversity, right? In physiological terms, this is the allostatic load, right? The costs of maintaining regulation in the face of chronic constant stressors, right? So one way that we think about this, just kind of a conceptual model, is as a balance, right? A balance of scales between our stressors and our resources, right? And so our stresses on that stress side of the scale, it can be, part of what weighs on that side of the scale is just kind of our everyday challenges, right? But then, for kids in immigrant families, we're thinking, we also want to think about experiences of discrimination, microaggressions, right? This example of my friend in third grade, right? This was a microaggression that he experienced. It surely wasn't the intention of the teacher or the school for him to feel singled out or to embarrass him or to kind of elicit some shame about, who he was or whatever, but that's how he experienced it, right? And so this is a small stressor that kind of weighs on that scale, right? And can kind of build up and accumulate over time. And then clearly, more significant experiences of trauma, waking up to an ICE raid or having a parent be arrested or deported, right? This is a single traumatic experience that, again, weighs heavily on that stressor side of the scale, right? This is weighed against the resources that we have, right? And when I'm using the term, when I say resources, I use the term somewhat broadly, thinking both about our internal resources, kind of biological disposition, our psychological resources, coping skills and things like that, but then also our external resources, our family supports and community supports, right? So speaking broadly, and I think, it's important to think about these resources and what's on these two sides of the scale. I think, if we focus on some of these resources and some of these resiliency factors, I wonder if that may help us understand a little bit of the paradox that you were speaking about, right? And so it's important to think about both sides of these scales, right? But what we do know is that as our stresses start to outweigh our resources, that the outcome is toxic or traumatic stress, right? And I've mentioned, this can look different for different people. It manifests in different ways. Sometimes it's sadness and anxiety or symptoms of post-traumatic stress, right? Sometimes it's impairment in executive functioning, cognitive capacities, attention and memory can manifest in behavioral problems, right? When we talk about trauma, particularly trauma occurring in childhood, it's broader than just PTSD, right? PTSD is a specific set of symptoms typically thought of in response to a specific incident, right? But when we're thinking about the chronic adversity of these daily stressors of having worries about what's going to happen to me or my family, the effect is more pervasive, right? And it affects, as I mentioned, general capacities and general functioning, and affects the developmental trajectory, right? It impacts our basic kind of regulatory functions that impact sleep and physical health and things like that. And it can, for kids, it can alter that developmental trajectory. Again, earlier a speaker mentioned the adverse childhood experiences studies, and these, are some of the research that laid the framework for understanding these altered developmental trajectories. Exposure to early childhood stress and adversity and trauma through neurobiological and physiological pathways leads to long-term health effects and health impact, physical health problems, impairment in functioning, substance abuse, higher risk for suicide, early mortality. All these are kind of long-term outcomes, long-term negative outcomes and consequences of these kind of daily chronic stressors and things that kind of accumulate on that stressor side of that scale of that balance. And basically, you can think about, this kind of happens through a resource drain, right? If we, as kids, if we have to focus our attention and our resources on dealing with the stress of a constant threat or a constant danger that's in our lives, right, then we're not able to devote our resources to the typical skills of development, right? Learning new skills, building our kind of physical health, trying out new things, right? So it's a resource drain in that way. And so this is how we see that those developmental pathways being affected, right, with these long-term consequences and outcomes. And this has a ripple effect, right? This affects us all. Folks today have also spoken about the impact on communities, right? So stress that affects individual also reverberates and affects entire systems and communities. So we've seen, this doesn't just happen on the individual level. We've seen, when there are rumors of or reports of ICE being in town or being around, we've seen schools, classes shut down. We've seen kids come or parents come and take their kids out of school, right? So this is really something that affects all of us, right? Whether we're from an immigrant family or not, right? This affects our entire communities. And so, again, schools, our systems can sometimes operate in a bit of a hypervigilant mode, right? Understandably so, because there is a real threat and danger, as many of our speakers have spoken to. But clearly that's not a healthy environment for kids' learning and safety and well-being. So what do we do about this? And basically the answer is we can think about building the resources, right? How do we kind of, build weight on that resource side of the scale to balance out the stressors and adversities that kids from immigrant families are experiencing, right? And luckily there are multiple opportunities, multiple levels of intervention, right? We can think about individual and family level interventions. We can think about community and systems level interventions, and we can think about societal and kind of political levels of intervention. So there are lots of opportunities for us to have an impact, to build resources. One thing that we're thinking about doing in mental health is complementing the important work that's being done by our partners in the legal fields. Folks have talked about the Know Your Rights workshops and family preparedness plans, right? These are all hugely important for establishing that sense of safety and security, right? Again, which we know is important for mental health. When families know what their resources are, when they know what their rights are, when they know the steps that they can take, that provides a sense of safety and security and stability for kids, right? So these very grateful and appreciative for the folks that are doing this work to deliver messages around knowing your rights. And as mental health providers, we're thinking about ways that we can complement that work by providing some space for folks, for kids and families to process some of the distress that they're experiencing, right? Sometimes kids and families have to get some things off their chest, so to speak, before they can really sit down and organize a preparedness plan, right? So this is where we can kind of fit into the equation and kind of contribute to the efforts that are taking place. We want to be thinking about putting out messages to normalize some of the responses that kids and families are having. So this is some of the efforts that we've been doing as well in our work and in our program, is kind of providing psychoeducational information about what are typical responses to stress, what can you expect when you're dealing with these fears and worries about what may happen to you or your family. And along with that, some guidance on when to seek help, right? Again, a lot of families have resources that they can access within their own systems, within their own communities, and kids may be able to use those resources effectively to cope with the stress that they're experiencing. And there may be times when you need professional help or support, right? And we think about when you see a functional impairment or a decline in functioning or performance, that this is kind of one of the signs that a red flag, so to speak. That tells us that we need, it's good to work with a professional. The affirmations, the communication that folks have been talking about throughout the day today around our hospitals and clinics being safe spaces are hugely important, right, for reassuring kids and families so that they feel more comfortable entering the healthcare and mental health systems. And at the same time, it's important for us to be doing outreach, right? I was excited to hear about some of the outreach efforts that Mr. Espinosa and Mr. Cruz spoke about, right? Because we have to be thinking about how do we integrate into the settings where kids naturally exist, right? So how do we provide mental health services in schools and community programs, right? Knowing that kids and families are going to have some fear or at the very least ambivalence about entering into our clinics, right? So how do we build resources in this sort of integrated fashion working in settings where kids exist? So in our program, we're looking at social emotional learning and mindfulness programs in schools, in schools, so kids get practice and can build skills in coping and stress management, right? And not to say that this is going to answer all problems, right? This isn't necessarily a panacea, but this is another tool that builds on that resource side of the scale, right? And so we want to be thinking about these sorts of programs and activities that help to build kids' resources. And then in our clinical interventions, we, just to kind of let folks know what we're doing a little bit, when we do see families coming into our clinics, when we are working in therapy, providing mental health services, we're thinking about, what we're doing basically is we have some great best practices and evidence-based approaches for treating anxiety and depression, and we can easily adapt these things to focus on some of the thoughts, feelings, and behaviors that are related to immigration stress. In our clinical interventions, we're working to take a broader, to recognize the broader context of immigrant families' experiences, right? Incorporating that into our work, understanding the histories of political and historical trauma that many immigrant families have experienced, right? And acknowledging that and working with that in our therapy work. And again, as was mentioned, I think by Mr. Cruz, we're thinking about how to work with families and caregivers on how to support kids, right? Providing some guidance around those efforts. Letting children drive the conversation, right? As adults, we have our own anxieties and worries and stresses related to immigration and policy, right? We don't want to impose our own anxieties on kids. We want to answer the questions that they have as honestly as we can using language that is developmentally appropriate depending on their age, right? So this is some of the things we work with parents and providers, is how to have these conversations and let the child really guide the conversation in that way. Again, as was mentioned earlier, we also want to think about ways to alleviate the kids' sense of responsibility, let them know that they're taken care of, and that there's plans in place that the adults are taking care of them. And in all of this, we want to promote reflective, empathic communication, right? Helping parents, guiding parents in showing kids that they understand their sense of anxiety and distress, right? When kids feel seen, heard, and understood, we know that this is essential for mental health and for positive outcomes. And so these are the sorts of interventions and programs that we're working with. And I will end there. Thank you.
Thank you very much. I think we've seen quite a wide array of experiences and information regarding some of the mental and physical health impacts and effects among immigrant families. And at this point, we have a few minutes for questions. So, Dana.
That was excellent. Thank you all so much. The transplant case, so many of those cases were very, very powerful, but we actually just did a presentation last week to the transplant team about our medical legal partnership. I don't think I really needed it. But it was really interesting for us to hear about a lot of the challenges in the transplant. And one of the transplant physicians was saying it's really an area for advocacy because they have a lot of children who could be getting a transplant from a parent, but the parent is undocumented, and so they're uninsured, and they cannot transplant from someone without insurance. So how to get these parents who could be donors to be able to get insured. And then in addition to the fact that some also would just be hesitant to enter the system because of the issues around being undocumented.
Yeah, I think it's such a critical issue, and you saw an ethics committee couldn't wrap their head around this. And if you think about why this makes sense for everybody, because if you don't do this for a child who's in renal failure, they're going to come into your ED all the time, and you can't refuse care there. So this is going to be as expensive or more expensive eventually. And of course, the kid could die. So I think we really have to rally around issues like this and tell the stories, because then I think people will start to understand why this is just wrong.
Hi, Elena, I had a question for you, and it had to do with the whole notion of social capital and that maybe contributing to differences. I think of the heat wave in Chicago where the mortality among African Americans was sky high, and yet the Hispanic community weathered that well, and whether in the little information that you showed us, people living in communities that maybe we don't know what about the community it is we have to look at. So I wonder what your thoughts are on that.
Thank you, Carol. It's such a pleasure to be here among so many friends. I think you are right. There are issues, whether it's the social capital, whether it's other kinds of community resources. Is it economic? Is it emotional? Is it informational? We really don't know. So this is where I think we need, as physicians, we have a sense of perhaps what our patients tell us, and maybe we get an early sense of what might be behind it. But we need to partner with social epidemiologists, with urban planners, with others, so that we can develop a more nuanced understanding. And then we have to put our money somewhere on, well, let's develop an index for that and then try to test it. But I think your issue, either heat or cold or the flooding was mentioned in the previous panel, there are some of those situations that are relatively predictable and that we might be able to study from a national or a natural experimental perspective. But at this point, I would say we don't know enough about what are those dimensions of community health that might impact the individual to develop a scale and then test it. But really good food for thought. Thank you.
This is for Dr. Flores. The advances in Google's translation services seem to be as rapid as self-driving cars. And my question is, what would you think of an experiment in which we brought to a hospital and randomly assigned professional translation services and Google translation services to see the extent to which in post sort of a session with the doctor, questioning the patients of how well they understood the instructions coming from the doctor.
Yeah, so I think technology holds promise, but right now you should not be using Google Translate because for a number of reasons. One of them is there have been a lot of advances in the last year. You probably saw that New York Magazine article or New York article about how AI is suddenly being part of this. But I believe Google still says for safety critical issues like healthcare, it should not be used because it's not the same as an interpreter. It doesn't know the different dialects. It doesn't get training in the ethics of interpretation. It doesn't know cultural issues. It's dangerous right now. And maybe one day that would be the trial that we want to do. But until we have clear-cut evidence that it's as good as a human interpreter, I don't think it should play any part in healthcare because it's still very dangerous.
So
Evidence
we're
of-
actually, I wanted to mention also, we just were awarded a $12 million grant from the National Institute of Minorities and Minority Health Disparities to look at precision medicine, precision health, and health disparities. And one project in particular, we're trying to do some evidence-based, and it's looking at Chinese and Latino populations and how genomic data and test results are given to those families and what the outcomes of the decisions that they make are based on how the provider gives that outcome, the information. So assuming that the language is not an issue, even just the culturally competent delivery and how that impacts the way the family does or does not act on that. So we're just starting these studies, but it's just the first of many opportunities that we should have to be able to study this. So I think we should maybe, I guess, one more question, or do you want to keep going?
Yes, hi, good afternoon. My name is Dennis. I work for Alameda County Public Health. Thank you for our distinguished panel. Dr. Matlow, on mental health for children of immigrants, you know, as we have been hearing, like the well-being of children is very much tied to the experiences of their parents. And you mentioned about the coping mechanism, about emphatic and reflective communication. But with a lot of, based on my experience with psychotherapy and social work with immigrant patients, they are looking sometimes for concrete actions that can be taken, something concrete that can be recommended that they can do, so that they can apply into their daily living so that they can improve their lives and improve their mental health and well-being. So any examples, I mean, since my experience was in San Francisco and I'm now in Alameda County, there's an ICE alert number. And for me, learning about that, even though I'm an immigrant, but I'm now a U.S. citizen, but knowing about that number made me feel empowered. So I could just imagine the impact of that for a lot of our immigrant families. So is there anything local that's going on in Santa Clara County, or what would you recommend as concrete steps that can be taken that can really have that direct impact to benefit our Latino population? I mean, our immigrant population, sorry. Thank you.
So that's exactly the focus of the next panel. So that's a perfect segue, some of these concrete resources that are there, right? I think, as you mentioned, just knowing that these resources are there, having some of these, knowing what your rights are, again, knowing, having the preparedness plans are very grounding, and right, and that helps with some of these concrete, what am I going to do in these situations, right? And then, you know, then we go to like the coping skills, right? Like having in the moment, like what can I do? Empowering people with some tools and skills that they can use in the moment when I'm distressed, when I'm very anxious, right? Having those concrete numbers that they can call are great, and then also knowing what I can do to kind of regulate myself, right? So we think about how to kind of build up that toolbox. So I think that those two things are really complementary, and we want to think about both of those things for kind of responding to some of the stresses that come up for kids in immigrant families.
Wonderful. Well, I'd like to first say that before we're going to take a 5-minute break, and we'll come back at